All right, very good. So just a review. I heard a lot of things there from Dr. Slattery that are resonating with me in peds. Physical exam, subtlety. These are the things. We all want to be tests. Well, we all just want to order tests. And the thing is that ordering a test, it doesn't require a lot of cognitive work. We're learning more and more that the reason why we make mistakes and we make error in our judgments is because it takes cognitive work. It's literally like doing biceps curls or bench presses all day long through our shifts. We're doing cognitive work, and it's so easy to just check the box for text. It doesn't take a lot of cognitive energy. But thinking through subtleties, listening carefully for physical or symptoms that are different, presentations that are different, listening to the intonations of families, these are the things that take cognitive work, and that's why you're exhausted after an 8-hour day. Sometimes you sit down and after an 8-hour day and you're like, oh, all I did was sit at the computer and talk to people. Why am I so exhausted? Cognitive work. It's being understood better and better, more and more. That's the thing that fails us. It's just like a muscle. It's just like your biceps after 12 reps, whatever, burning. You fail because you don't think. Ordering tests are easy. Performing a careful physical exam, making yourself do it, thinking about differential. Those are the things that lead to error. Okay, let's go on. So bacterial meningitis, let's learn a little bit more about this. In the first 30 minutes of our discussion of pediatric high risk, we talked about subtlety, we talked about physical exam, we talked about listening for differences. We learned that cardiac presentations can occur in children with chest pain and with shortness of breath and syncope as well. We learned that not all fever is the same. We have to listen for subtlety. What are the things that are going to make that patient go into your numerator, not the denominator? We learned that we need to be parsimonious with our test ordering and not do more cognitive work, thinking about what is going on with the patient, doing more physical exam. We learned that febrile seizures, if you're going to use that as your diagnosis, you have to understand what a simple febrile seizure is, and that a 12-year-old does not have a simple febrile seizure. That, by definition, is outside the realm of simple febrile seizure. We learned that with bacterial meningitis and sepsis, time is of the essence. You have to give antibiotics early. Don't pass the buck. Don't wait for the next test result. That is called a punt on your part. You have to drop back and make the touchdown pass. Do the right thing. Okay, let's move on with bacterial meningitis. It's still out there with all these vaccines and everything. It's actually making it even harder for us because it's great that bacterial meningitis is being prevented by all these vaccines, but it is still out there and it is still resulting in malpractice because it still exists. We don't see it frequently, and we have to think about it, and we have to LP patients. So Dr. Thigpen is a big PEDS ID guy, looked at a huge swath of the U.S. population and published this back in New England Journal back in 2011. And he found out that there's only a few, like 600-700 cases of bacterial meningitis a year in this 2-month to 17-year-old age group. Like we said before, under 2 is the highest risk population. I was curious about what kind of cases do get sued for meningitis, and so I asked this database to search trial verdicts going back, looking at the last 25 U.S. trial verdict cases for bacterial meningitis. They only had to go back 6 years to find 25 cases in which they were jury verdicts. Remember that jury verdicts are only 5% of total cases, so that represents only 5% of all bacterial meningitis malpractice cases, most likely. And I found a whole slew of cases, and nobody was really immune from this. You see here, I did the year that this occurred, the age of the patient, the result of the injury, the diagnosis initially, how long the delay was, who was the provider, how many visits took place, whether there was an LP performed or not, and what was the award. And you can see here some very, very big awards, some very, very serious complications here, hearing loss, death, severe disability, some very big awards. And the thing to know about this as well is that no one is left unscathed. You saw that I had some of them were in the primary care office, but also I can tell you from looking at these, I learned some very major pediatric EDs at large children's hospitals that you would know the names of in a moment were also litigated against for bacterial meningitis. So this is not the bad doctor phenomenon. This is a challenging, difficult diagnosis with a high rate of medical malpractice being associated with it. So we have to be extremely vigilant, and that means you have to do a lot of lumbar punctures or send patients for lumbar puncture if you are worried about a sleepy or irritable child. Steve Green and Baruch Kraus and Lisej Negrovic are very famous ER providers and pediatric providers, and they wrote this essay about sick kids look sick. And I got to tell you, in my 30 years, that is true, but sometimes they don't. Sometimes they can trick you, and I just wanted to go over this one little case here that was an exclamation point on that fact. So 8-year-old girl came to me, and we're in the ER, we get a little high-minded sometimes, like we're the bottom line. And there's a large pediatric practice in Las Vegas run by a lovely lady in her 70s who has a bunch of physician's assistants and NPs working for her, and they send us a lot of patients, and we're grateful for that, but sometimes we roll our eyes a little bit. So this little young lady was sent to me by a woman who was a nurse practitioner, and she said, I got an 8-year-old little girl who's got a headache and a fever. I think she has bacterial meningitis. Now, when I got that phone call, I was kind of busy. I kind of said, okay. I hadn't seen a bacterial meningitis in an 8-year-old in a decade, and so I wasn't that impressed. Nonetheless, she comes over, she walks into my department. She had had a fever and a bifrontal headache for about 3 or 4 days. She had had no vomiting or diarrhea at home, but she vomited when she got to my ED. She had been given some Tylenol. She had all her vaccines. She had been hospitalized as an infant for intestinal surgery. She looked tired, but she wasn't toxic appearing. She was quite tachycardic, as you can see here, so we got to pay attention to our vital signs. Boom, 142 for an 8-year-old. But I didn't walk into this room and say, oh my God, this kid's got bacterial meningitis. She vomits once in the triage. She's given Motrin fluid, Zofran. She did not have meningismus when I examined her, and it was very impressive, but she did have what I would call as a funny headache. When I examined her, I laid her down to do a Kernighan-Brzezinski sign, and she had a negative Kernighan-Brzezinski sign. She had a supple neck. But when I laid her down, she went like this. That's kind of weird, right? Have you ever seen a 9-year-old or 8-year-old do that when you laid them down? Kind of go like that? I thought that was odd, personally. I call that a funny headache. I'd say that she had a funny headache. 90 minutes after she arrived, she had been given the ibuprofen, the Zofran, and the IV fluids. The resident that was on at the time, as a matter of fact, came to me and said, I think this kid's got viral meningitis. You ever have that feeling when you walk out of a room? It was June. This kid was in June, actually. And so it was enteroviral season, and the resident said, I think she's got viral meningitis. And after we give her this treatment, she's sitting there coloring in a coloring book. So this is not your poster child for bacterial meningitis by any stretch of the imagination. But in this instance, her white count was a little bit abnormal, 16,000. She did have a left shift. And she had what I call reactive hyperglycemia. She didn't have any reason to have a little bit of elevation. So what is that? That's stress, is what that is. So I'm getting a little bit weirded out by this kid, even though I'm saying to myself, this kid's trying to fool me. And I've heard people say, well, she's got viral meningitis. We don't have to tap her. It's just viral. It's going to get better on its own. I said, we're going to do a lumbar puncture on this child. She has what I call a 3-strike you're out rule. If I have 3 things that occur to me in a patient who's borderline and they make me worry, I take the extra step. So in this case, it was a nurse practitioner who called me, and I wrote it down on a piece of paper. I think this patient has bacterial meningitis. And I got to say bravo to this nurse practitioner because she saved my butt, because she was right, as it turns out. So strike 1 is the referring provider said, I'm worried about bacterial meningitis. So strike 1. Strike 2, on my physical exam, I've seen a lot of kids with headaches and a lot of kids with different things. I've never seen a kid, when I laid her down, go like that. That was just weird to me. So that stuck out in my head. So that's strike 2. Then strike 3 was the abnormal blood test, the abnormal markers. I thought that was a little bit weird too. And then strike 4, if you will, was that I wanted to prove to this resident that you got to do an LP in kids that you think have viral meningitis. Why do you have to do it? Well, here's my little explanation there. That's why. She had pneumococcal meningitis. And if you look through that list of cases that I got from the trial verdict list, several of those had cases of pneumococcal meningitis in fully vaccinated kids that were sent home. Yes? I hope so. She would have been admitted anyway, but I've seen upper lobe pneumonia cause neck symptoms in patients. But the lesson here is you don't have to have a stiff neck. Everyone thinks that. You do not have to have a stiff neck. You can have a funny headache. Some people talk about making people jiggle their heads like that or do stuff like that, but a funny headache should make you worry. And we can make these patients better, because I'm telling you, this kid was watching Pretty Ponies and coloring in a coloring book. Yes?
Question I have is, meningitis,
yes.
antibiotics,
yes.
or, ear infection, or throat infection.
Yes, exactly. So there's definitely lots of partially treated bacterial meningitis, absolutely. And so patients that have antibiotics on board, you got to treat differently, for sure. Yes. So, very good. All good questions. Partially treated antibiotics. Partially treated meningitis. So why do we get sued? Low incidence, patients present early, previous physician visits, pre-treated, concomitant focus of infection, all the things that you're talking about exactly. Those are the things that can trick you. Normal white counts can be misleading, delaying the LP, parents' history is vague, language barriers, that's a strike for sure. Language barriers are all, I always consider that a strike one on me. Language barriers, I don't care if you have an interpreter or not. Lack of a good follow-up plan and delays in antibiotic therapy. All are strikes. Let's go to this next case. Let's get off meningitis for a second. I love this case. 16-year-old boy with abdominal pain. Acute onset right lower quadrant pain. Nausea, vomiting. Examined in the ED. He's a little stiff in his right lower quadrant. Ultrasound, CT of the abdomen are negative. General surgery consult. He's discharged home. Could this still be appendicitis? Absolutely. So close follow-up in this case is absolutely essential. We have to think about intussusception, gallstones, kidney stones, viral illness, constipation, strep pharyngitis, all these different things in abdominal pain. So why do we struggle at appendicitis? Well, because it's a challenging diagnosis. The appendix can be downward pointing. I'm always talking to the residents about the appendix that's dangling in the pelvis. It's not touching the anterior, not touching the peritoneum up on the anterior wall of the abdomen. That can present with urgency. I had a kid one time with appendicitis. His chief complaint was, I gotta pee, I gotta pee, I gotta pee. It wasn't even abdominal pain. It was urgency as his inflamed appendix laid on top of his ureter. I've had retrocecal appendicitis that presented with back pain or limp as the inflamed appendix laid upon the psoas muscle. So, if only the kids read the textbooks, right? So so appendicitis is still a pretty high risk for medical malpractice. It's still very high up on the list, and particularly in the very young. There's definitely a difference in presentation at ages 5 and under. Look at these numbers here. This is an old study, but nonetheless, I think it rings true. The younger you are, it's inversely proportional to the percentage with which present with rupture. Because in a 1-year-old and a 2-year-old, distinguishing appendicitis early on from gastroenteritis is extremely difficult. They look identical in many instances. I ask crazy questions like, did he sleep through the night? I worry I think appendicitis pain makes you not sleep through the night. I think appendicitis pain makes you walk funny most of the time. I ask these crazy questions like this, and all of these things strike me as strikes against the patient. There was a nice study published in 2017 looking at all the Medmal jury verdicts in the journal Clinical Pediatrics in 2017. This was published by some guys out of UCLA. They looked at over 200 cases, and there were 150 cases of delayed diagnosis. There are still people dying in this country of appendicitis. We've had a couple here in Las Vegas, fortunately not through our ED, but patients that were sent home and ended up dying. It costs about $1 million usually if you lose the case. And these authors thought there was an increase in the number of severe cases over the last few years. And why is that? Because the classic presentation of periumbilical pain, anorexia, nausea, vomiting, and migration to the right lower quadrant in one large study showed only about 50% of the time was that the presentation. So these cases can fool you, and close follow-up and serial exams and listening to the families are very, very important. Also, a third of the kids can have diarrhea. You're not supposed to have diarrhea with appendicitis. Well, these kids don't read the book. Only 80% of the cases had fever, so some kids don't have fever. Some kids don't even complain of pain initially. How do you make that diagnosis? They present with vomiting. And not everyone has anorexia or loss of appetite. I distinctly remember an appendicitis case, a lot of kids come to Vegas for basketball tournaments and volleyball tournaments and talked about minimizers and amplifiers and minimizers and teenagers. This was a minimizer for sure. This kid was from Arizona. He came in for a basketball tournament. He was taller than me, big kid. And on the court, he doubled over and vomited. And the coach said, "That's weird," and brought him to my ER. And this kid, I remember walking into the room, he was sitting on the end of the bed, his legs were crossed, and he was like this, in his basketball uniform, like this. He wanted to go back to the game, right? But I examined him, and he was kind of pushing against me, didn't have a fever, but he was kind of pushing against me, didn't want me to examine him a little bit there. And I remember sending him for a plain film. I don't get plain films anymore, but I remember back then, this was in the 90s. And I remember him walking to the x-ray machine. He just walked like this, like it was nothing. But I examined him again, stiff, right lower quadrant. Got a white count, was 15,000, CT scan, acute appendicitis. So that was a minimizer. Big differential diagnosis. We made a pact in my group years ago that we don't send home patients with gastroenteritis or constipation as the diagnosis. Why? Because it tells the family we've got it figured out. You could be right most of the time. Just don't let patients with abdominal pain go home thinking absolutely, positively, you have gastroenteritis or constipation as the cause of your abdominal pain. Your words are powerful. I remember a kid that I had that died of bacterial tracheitis, and he had been to the doctor 3 times with croup. And I resuscitated him on Christmas Eve back in 1997. And that little boy ended up dying, unfortunately, of bacterial tracheitis. And on the 4th presentation, he seized at home and he couldn't get his airway. And I remember asking the family, because they were very bright people, I said, what made you not come to the doctor earlier tonight in this case? And they said, the doctor told me it was croup. Your words are important. What you say. You have gastroenteritis. That's what's causing your belly pain. Go home. It'll be better in 3 or 4 days. Your words are powerful. Be careful. So how do we get better? Maintain a high index of suspicion. Get really good at distracting people in your physical exam. I always talk about what the kids are interested in. That's why I'm in my history. I take them up, what do you like to do for fun? Oh, and when I'm examining their belly, I start asking them about their basketball practice. I start asking them about their band practice. I ask them about, wrestling, whatever they're into. And so I'm distracting them during the exam. Get really, really good. And also, you don't have to gnash really hard. Percussion tenderness and percussion weakness, wincing, is just as sensitive, just as good as a rebound physical exam. If you read the old Copes' diagnosis of the acute abdomen. Remember that ultrasound has what we call spectrum bias. What is spectrum bias? Spectrum bias observes that the test gets more sensitive as time goes along. So in the first 24 hours of appendicitis, ultrasound has been demonstrated by careful research is not as sensitive as it is in the second 24 to 48 hours. So that's spectrum bias. Be careful with ultrasound. And also know your ultrasonographer, because not all facilities are the same with regard to their sensitivity. CT is definitively better test in the first 24 hours, unfortunately, goes with having increased radiation to the patient. So, review of high-risk appendicitis cases. Patients, I've missed an appendicitis once in the last 10 years that I know of, and it was a kid who presented very, very early. It was a teenage boy who presented in the first 4 hours. He had severe lower abdominal pain at home, vomited, came into the ED, came into the clinic, actually referred to me. When I saw him, he looked fine. He was a minimizer for sure. He wanted to go to school. It was 7 o'clock in the morning. Wanted to go to school. He had no abdominal pain. Luckily, I said, come back if worse, and he did, and he had appendicitis later in the day. Normal white counts do not rule out appendicitis. Ultrasounds that cannot visualize the appendix. Young children under 5 years, and also be careful of the non-English speaking family. What about your particular hospital? It's also important to know whether your hospital, your surgeons, your radiologists, your nurses are comfortable taking care and evaluating patients for appendicitis. If you have to transfer the patient in to another facility, that time is important in the diagnosis too. So just refer them into another facility. If you think the patient has appendicitis, give him IV fluids and antibiotics beforehand. So remember that kid that we talked about earlier in this lecture about the lower abdominal pain? We were talking about, could he still have appendicitis? Yeah, he could. He also could have testicular torsion. So that patient that we described before with 16-year-old boy with sudden onset of right lower quadrant pain, he had a negative CT for appendicitis and was sent home. He didn't have appendicitis. He had right testicular torsion, and unfortunately ended up having to undergo a right orchiectomy. So the ED physician was sued in that case because there was no testicular exam done and no discussion of the possibility of other diagnoses. Case was settled for $300,000. Teenagers do not, particularly boys, girls too, but they do not want you looking at their junk, okay? That's basically the thing. So they'll come to you with abdominal pain as their chief complaint for testicular torsion. They'll even distract you away from their genital exam. They think that somehow magically you can fix them. They have some magical thinking too. They will not tell you necessarily that their groin is hurting. You have to break that barrier, as Dr. Slattery was saying, get them undressed and do a full exam. If they are uncomfortable with the opposite sex examining them, find somebody else to do it. If you go through your career not examining the genitalia of patients with abdominal pain in males, you will miss the diagnosis of testicular torsion at some point. So if you're concerned about testicular torsion, get an ultrasound. Do not rely on physical exam alone. We're not as good at it as we should be. Get an ultrasound and get your urologist on board early. This is a time-limited therapy. If you go 8 to 12 hours of ischemia, you're not going to get that testicle back, and it impacts on fertility. It has cosmetic implications, and you will get sued. So consider testicular torsion. There was recently a nice publication done in the Journal of Peds Urology looking at the entire country's appellant cases for testicular torsion over a 30-year period. And what did we learn? There were 53 cases that they found. The ED doc got sued in a third of them. A third of the cases presented with not, I have pain in my junk, I have pain in my abdomen. You must examine the genitalia of boys with abdominal pain. The average settlement is now, I remember when I first was in training, the average settlement for a testicular torsion was $100,000. Inflation has kicked in, and now the average settlement is $490,000. It's a fascinating study, actually. 6 of the 53 cases had a CT of the abdomen as the first ordered test. You guys order a CT scan to rule out testicular torsion in your facility? That's what's known in the business as poor form. You don't want your radiologist calling you with the normal appendix, but doctor, please examine the groin because he's got a torse testicle. Interestingly, too, testicular torsion can have a false negative ultrasound. 16 of 25 cases in which there was lawsuits involved that had ultrasound performed, it was a false negative ultrasound. So testicular torsion can be tricky, even for the ultrasonographers. This is another interesting study. There's several pieces of research now that have documented this. I know everyone talks about the procedure of performing the manual detorsion. Well, if you're out in the rural areas and you've got a long way to go for this patient to get to a surgeon, that's all fine. Just understand that in as many as half the cases, the torsion is in the other direction. Remember, we were all taught in medical school that all the torsion is medial, and that you just do the open the book thing, and then you fix them. Not so right. these surgeons, I think this is a hospital in Pittsburgh, these surgeons documented a series of scrototomies that they were performing for testicular torsion, and they found that nearly half the cases, the torsion was in the other direction. And the other problem is, too, is that sometimes it can give you a false sense of security. Sometimes you'll detorse them, they'll feel better, but you didn't detorse them all the way. And there's multiple rotations. And so you'll turn it around once or twice, and actually it was twisted 4 times. I'm aware of cases in which those patients were admitted to the floor waiting for orchiopexy the next day, and they infarcted overnight and lost a testicle. So the treatment for a torus testicle is emergent exploration and orchiopexy. That is the standard of care, in my view, personally. Now, for females, ovarian torsion, even trickier. Fortunately, not as common as testicular torsion, but it does exist. Ovarian torsion is a real bugaboo. It's fortunately rare, but you've got to consider it in your young female patients with lower abdominal pain. Make sure when you're doing an ultrasound with a woman with abdominal pain that you consider ovarian torsion and do a pelvis on their assessment. So, remember, appendicitis, tussoception, gallstones, kidney stones, all those processes. Remember, torsion of the genitalia as well. Okay, down the home stretch here. Batteries. Batteries in the airway of children are a very, very dangerous diagnosis. So when you hear my child swallowed a coin, you're not going to get into too much trouble with that. Make sure it is actually a coin. Make sure it's not a battery, because that can be lethal. This battery right here, you can see the classic double ring sign, right? That has to be removed quickly. The aorta right there is adjacent to the esophagus, and if the diode there starts leaking and erodes through the esophagus, it only has a few millimeters to go when it's in the aorta, and you have yourself an aortoesophageal fistula, and you have yourself a fatality. So these are got to be removed quickly. If you're out at a rural facility, you can start giving the patient honey or sucrafate on the way in. But if a parent says coin in your facility, start thinking battery. So time is everything. It requires immediate removal. Call the poison center. There's actually a button battery hotline that can tell you if you know what kind of battery it is and where it is in the patient's aeroesophageal or gastrointestinal tract, what has to be done. But esophageal battery is an absolute emergency. It also can be very dangerous when it's stuck to the septum. This can cause necrosis and permanent effects on the cosmetics of the child's face if that's not removed quickly as well. And they stick as well. You'd think you could just grab it and pull it out, but once it begins to leak the material and fixate, it can be very difficult to remove. Other things that cause litigation against providers with pediatric patients is wound care. I think you probably are all doing this now, but if there's glass involved with a laceration, even if you think you can see what's in the wound, get an x-ray, because there's case after case after case in the annals of medicine of retained foreign bodies that lead to pseudoaneurysm of small arteries or osteomyelitis in 6 weeks of a PICC line for osteomyelitis, all other kinds of problems. So be careful with your glass. Make sure you document carefully that you're able to visualize the bottom of the wound. You didn't see any additional radiolucent foreign bodies. Make sure when you have a finger lac that you put a tourniquet on the base of the finger for a period of 5 minutes to carefully examine for foreign bodies because it's so bloody with digital lacerations. If you need extra time to do a good examination on a wound, you got to sedate the child or give pain control so you can do a good exam. Make sure your dressings on the extremities are not tight. Make sure they're bulky and loose. And make sure you have good wound follow-up in all your wound cases. Here's a case that resulted in litigation. 2-year-old little girl with a laceration of the finger slammed in a door. There was a partial amputation. There was no fracture seen on x-ray. It was sutured, given pain meds, antibiotics. A dressing was placed and the patient was discharged. They were asked to return in 2 days. The dressing is unwrapped 3 days later. The little finger had been caught in the splint. It had been wrapped too tight, there was darkness and duskiness of the digit. The ring finger looked great. It was the non-injured finger that was affected by this incorrectly placed splint, and the case was settled for $30,000, and the physician had to be reported to the data bank. So if you didn't put the splint on in your ED, make sure before the patient goes home that it was placed correctly. Okay, what about the irritable baby, the fussy baby? This is a bane to our existence, particularly in the middle of the night. You got to consider meningitis or sepsis. You got to consider non-accidental trauma, consider drug exposures, UTIs, torus testicles, intussusception, corneal abrasions. Be careful if you're going to place colic on the diagnosis line that you have ruled out all these other dangerous pathologies. Take time to listen to the history and document it well. Watch the child for a period of time. When my colicky babies, I always watch the child for a period of time in the ER. It's better to be careful in these cases than to miss a very serious diagnosis. You don't have to do every diagnostic test in these babies. You can be driven by your history, but the younger the infant, the more time you want. If you haven't seen a lot of colic, then be more careful with it. Colic, by the way, usually starts in the 3rd week post-confinement, post-state of confinement, and usually goes on for several weeks in duration. Usually it's in the evening, and usually it does not affect feeding. The child usually feeds his way right through the colic. It's usually probably the feeding that's causing the colic because they eat so much, but it doesn't usually affect feeding. Make sure you do a complete detailed exam on these young infants. I like to put these little ones that come in with 3 or 4 weeks of age, I like to put them in the warmer. We have a little warmer in my department. I like to put them in there so that they're nice and warm and relaxed, not crying, and I can do a good careful exam of every digit, make sure they don't have a hair tourniquet, make sure they don't have a torus testicle, look for any signs of abuse. Always be careful about ear bruising or post-auricular bruising. Anyone that's not cruising does not bruise. So if someone's got a truncal bruise and they're not yet cruising, they're not pulling themselves up to stand and walking around, those kids should not have bruises. Unfortunately, we have a lot of kids being abused out there. Make sure the extremities go through full range of motion. Kids are chubby, their extremities are chubby. When they're only 3 or 4 months of age, it's not that hard to miss the early presentation of a fracture. Okay. So, non-accidental trauma. Unfortunately, we all have to be vigilant for this diagnosis. It's very, very challenging. I don't have any easy fix for you, but I do think that you should look carefully for occult bruising. Everyone knows what a frenulum is, right? You've got a frenulum. The baby has a frenulum that attaches the upper lip to the gingiva. They have a frenulum that attaches the tongue to the floor of the mouth. Look at those frenulums. Shaken babies often will have tearing. Orofacial trauma will also often result in tearing of those frenulums. Look there. Look for ear bruises. Palpate the skull. Make sure you don't feel anything unusual. I remember a little baby that came in with a chief complaint of the mom saying, my baby's chest is popping. And I was like, what? My baby's chest is popping. And I was like, what are you talking about? If you hold the baby's chest, you could actually feel this little crepitance. And the father had been abusing that baby, and the baby had rib fractures as a chief complaint. So look for long bone fractures, look for atypical burns, look for unexplained injuries, look for injuries where there's no history, there's no clear history. Maintain a high index of suspicion and err on the side of reporting I don't know if you do your own reporting to CPS in your place or if you have the social workers do it, but this takes a team of people to get it right. Okay, what about this little kid? 3-month-old comes in fussy, poor feeding and fever, 102, mottled skin, scattered wheezes. Sepsis workup is initiated, IV fluid bolus is given. After the fluid bolus, the symptoms seem to worsen. The kid's breathing harder, he's wheezing more. He's given a second bolus of saline fluid for concerns of sepsis. Now his heart rate's 190, respiratory rate is 100. What's going on here? He's intubated and brought to the PICU. This circles back to our original case. This is a case of myocarditis. So not all that wheezes, not all respiratory distress is fever and bronchiolitis. You can get inflammation of your myocardium as well, and that results in poor ejection fraction and pulmonary edema, non-compliance of the lungs, tachypnea, and it can look very much like bronchiolitis in the middle of the winter season. However, in general, bronchiolitis gets better with a little bit of IV fluid, a little bit of suctioning, things like that. Period of observation again, those patients look better. If you watch a patient of that type and they get worse over the course of time, shoot a chest x-ray, look for cardiomegaly. 90% of myocarditis patients will have the enlarged heart. So be careful for myocarditis. They have a very bad prognosis in many cases. So persistent tachycardia with poor peripheral perfusion, always get good at feeling pulses, doing good physical exams. Kids with bronchiolitis generally have good peripheral pulses. That helps you distinguish a patient with myocarditis and poor left ventricular ejection fraction from a patient with just simple bronchiolitis. Consider myocarditis in chest pain patients and older children. Never ignore an enlarged heart. And consider doing a troponin on those bronchiolitis patients that just don't seem like the other patients that you've seen this winter. Other high-risk scenarios, as we discussed, is when you can't get a good history. When there's a language barrier, and even with interpreters, sometimes I find it's difficult sometimes to see the subtleties in the history. When the provider who brings the patient in to the ED is not the provider who was watching the child for the last 48 hours, that's another high-risk situation. I've been duped in those situations as well. Be careful with your medications. Always use milligram per kilogram. Make sure you're getting weighed in kilograms. And be careful with AMA scenarios as well. The patient with the so-called ALTI episode, or brief, now called the brief or the BRU episode, a brief resolved unexplained event. Be careful with those patients. So this is a case, 1 week old comes to the ED by EMS with a stop breathing episode. Family spoke limited English. Triage nurse took the history from the family with via broken English. Uncle demonstrated that someone was tapping on the baby's chest. Triage nurse said, "Did the patient stop breathing?" The uncle said, "No, I don't know. He wasn't the primary caretaker." Resident also took a history without a translator and wrote down there was limited language skills on the part of the family. Patient looks well on their physical exam. Patient's discharged, comes back within hours with another apneic episode. It gets intubated, put on ventilation, goes to the ICU, and it ended up having RSV. Ended up succumbing to an anoxic event. And there was a award to the family, luckily for the defendants, for only $400,000. But obviously, in the litigation, they said they should have gotten a translator, even though it was Vietnamese. You owe it to your families to get an interpreter. And this, I can't emphasize this enough. You've got to speak to the family in their language. Don't use and it should be a hospital-approved interpreter as well. The history is usually the foundation of the diagnosis with pediatrics. You've got to have the history. Otherwise, it's difficult to distinguish one kid from the next. So be careful with your documentation in kids. Don't use terms like obese or FLK. You can use terms like, I use elevated BMI. Don't do things that can make the family angry later. Do not alter your charts later. Do not block out or erase after the fact. Make sure you document your consultant times. Most EMRs now have that built into their systems. Document repeat exam and patient improvements. Things you should not put on the chart. These are just the old George Carlin things you can't see on television. These are the things you can't put in the chart unless you're going to do a lumbar puncture and admit the kid and do a full workup. Don't put lethargic or listless. Don't put irritable or somnolent, whining, mottled, ill-appearing, drowsy, sleepy, don't say that and then discharge the patient. You can give therapy and then reassess and redocument, that's fine. Or you can do a full workup at a lumbar puncture and those patients, that's fine to document the accurate exam. Make sure you discuss with the triage nurses any differences of opinion that you document in the chart as well. You want to make sure that you're on the same page. If they put something in the record that says the patient is irritable and you don't think the patient's irritable, ask the nurse to describe the actual behavior that they saw, or you describe the behavior that you saw. Make sure it's clear. The documentation of your exam should start with a good general description. This is an awake, alert, 9-month-old who's well-appearing, well-hydrated, no acute distress. If that's how good the patient looked, that snapshot is important. Make sure you put it in the chart. Things to avoid, again, I would be careful with definitively diagnosing somebody with a specific viral illness if the chief complaint is something with pain. So if someone comes in with headache as the chief complaint, I would not say viral illness and be dismissive of it. Put headache and say, we think it's a viral illness, if it gets worse or not better, come back. Don't use terms like early otitis media, touch of pneumonia, things like that. Be confident and firm with your diagnosis. If you're not confident, don't document that. Always be careful with bounce back visits. We probably have stated that previously in this course. If the patient is a return visit, recognize the fact that the biggest obstacle to a correct diagnosis is often a prior diagnosis. That's the way our brains work. We like to anchor on other people's thought processes. It requires decreased cognitive energy, so we tend to defer to the provider before us. I would recommend, it's one of the funnest things in the world to prove your colleagues wrong, right? So start from the beginning and go from the beginning and take the whole process through again. Don't rely on the previous diagnosis. Repeat presentations are often the presentation of non-accidental trauma, so be careful of that. And think about the next step. Do a chest x-ray, do a urine, do a strep swab, consider meningitis, consider the atypical stuff. If there's a third visit for somebody, strongly consider admitting the patient to your facility. If something comes back 3 times in a short order, like a week or something like that, 3 times with fever, 3 times with limp, 3 times with abdominal pain, something is being missed here, or at the very least, one of the questions that the family is asking is not being answered in your ED. So strongly consider admitting that patient, or at the very least, discussing the case with the primary care provider and tightly closing the loop on those patients. Obviously, medication errors are a big concern with children. Make sure you're weighing in kilograms. Make sure you're double checking your doses. Make sure you're using a reference. Call the pharmacist at your facility if you have to. Don't let these holes in the Swiss cheese line up and cause a problem for your patient. Okay, let me skip this case. Getting towards the thing about AMA is that make sure that you do not allow your child to go home with a family if you think the patient has a life-threatening condition, if the caregiver does not have good judgment or is altered, or if you suspect child abuse. Don't allow patients to go home. The last point I want to make here, because I'm losing my voice, is to be careful with being too strict with algorithms. Everything's an algorithm now. There's a guideline for everything. Sometimes you've got to relinquish yourselves to the judgment of the family to give in to a parental concern that is perhaps better than your judgment in this instance. And this is a case that I like to go over. This is a little girl that I had at 3 o'clock in the morning. I had gotten crushed that night. She was my 30th patient of the day. I was tired. She came in with a nosebleed that was about 15 minutes in duration. I kind of had this rule in my head that if you don't bleed for more than 15 or 20 minutes, I'm not worried about it. The mother was Spanish speaking. I understood her a little bit, but I was not as worried about this bleeding nose as the mother was. The vital signs were normal. Her exam was normal. I reassured the mom, and I was literally about to walk out of the room. I was saying, it's just a nosebleed. It's okay. She scratched her nose. No big deal. The mother literally grabbed me as I was leaving the room in my, 47-second assessment and said, please, please, please do a blood test on my baby, please, in her broken English. And I don't know if I was just exhausted, but I acquiesced and said, okay, I'll get a CBC. So I get a CBC on this kid. Platelet count was 3,000. So that's a situation where the kid had ITP, and the mother's judgment and insight was greater than mine. I was tired. I had been cognitively overloaded, and the mother was right. And thankfully, I listened to her and didn't argue. She had ITP. She got IVIG. The only manifestation clinically of her platelet count of 3,000 that morning at 3 o'clock in the morning was her nosebleed. She ended up getting purpura all over her body the next day, but that came the next day. So I would have looked pretty silly if I had sent her home. She did well. She got IVIG. But that's known in the biz as a near miss. And so listen to your family. Listen to your parents. They sometimes know better than you when you're tired and on your last leg. And I'm going to have to stop there because my voice is going. Thank you very much. If you have any questions, I'll be glad to take them afterwards.